Welcome back. Now that you understand about pulmonary function testing and the lung volumes and lung capacity, let's look at some other lung function testing. Now we're going to look at stuff that can be done in any physician's office, or in fact, a lot of this can be done in your bedroom. And in fact, this is more the day-to-day function testing. And so we're going to use spirometry to look at lung function. So we're not just going to be looking at volumes in this one. We are going to look at the volume of air during inhalation and exhalation, yes, as we did in normal pulmonary function testing, but now we're going to be looking at volumes over time. So we're going to be looking specifically not at the speed of inhaling, but the speed of exhaling. And so how fast we are able to exhale the air in our lungs can be used to diagnose things like asthma and chronic obstructive pulmonary disease, or COPD. And in order to do this accurately, you can put a nose clip over your nose and you're going to be breathing in and out through a tube, just like you do with the normal pulmonary function test. However, at this point, I think most adults, for the short amount of time to do the super easy testing, can just, use your finger to hold your nose, or just realize you're not going to exhale through your nasal cavity. So the first thing that we need to talk about is what's called the forced expiratory volume, or the FEV. This is the amount of air that can be forcefully exhaled from the lungs. So what that means is we're not going to breathe out like, yeah, I'm going to hold it. Yeah. But in fact, we're going to give a and push as hard as we can. And yes, we're going to continue exhaling for 3, 4, 5 seconds. So it's something you really have to kind of practice doing. Is like, you're going to go, oh, keep on exhaling. Okay, now we have our 5 seconds of exhalation. And when you look at this or measure this, you will get a curve, which most probably looks something like this, where you can see the vast majority of the volume exits quickly, and then over time we have smaller volume leave, but it does take a few seconds to reach our maximum. The next thing we're looking at is what's called the FEV1, which is the forced expiratory volume at 1 second. So this represents how much air can you force from your lungs in the first second of exhalation. And so if we take that graph from before and 5 seconds across the bottom, if we go at the 1 second mark, which is on the x-axis, and go until we intercept the graph, and then we go to the y-axis and we can read the volume in liters. So it's going to be a fraction like 4.2. A lot of students like to write 4,200 cc's, but it's actually reported in liters, 4.2 liters, for instance. I just made that up. That's not a number that you're going to have. It's just a random number I picked. And now that we know our FEV1 and our forced vital capacity is the number at the very end, okay? So we go on the same graph, we find the very end, take it across, and that's what's called our forced vital capacity. So after taking the deepest breath possible, the amount of air that can be forcibly exhaled. So in case you didn't get it, it's not a normal breath that you're then exhaling. You're breathing in and then forcibly exhaling. So in normal people, what you will notice looking at the graph at the 3 second mark, we probably have about 90% or more exhaled. But this will change in various lung diseases, as we will see later on. So now we have an FEV1 and an FVC. Okay, this right here, this number would be the FVC, and then this number right there would be the FEV1 on this person. So on this person, you can see the FEV1 is under 4 liters. As I said, A lot depends on your height and your sex. So we can take those two numbers, the FEV1 and the FVC, and make them a ratio. And so the normal ratio is above anywhere from 75 to 85%. And these numbers can be used to diagnose obstructive and restrictive lung diseases, which I'll talk about shortly. So if you were in the lab and you were doing this on the spirometry that was in there, you would get a printout. And yes, you also have the graph and you can manually read it yourself, but it also does usually just print out the numbers for you. Notice they are in liters. And so here's an example where somebody had an FEV1 of 2.66 and an FEV of 3.05 liters. So if you put the 2.66 and divided by the 3.05, that gave a ratio of 87.3%, which was perfect. At first glance, you might look at that FEV and the FVC and think, small numbers. Maybe it's a small person, you don't know, but their ratio is normal. Or maybe it is somebody with lung disease, and so only looking at the ratio gives you a false sense of security. So let me talk about two broad categories of lung diseases. The first is obstructive lung disease, where we have a reduction in airflow. When we are exhaling, air remains in our lungs during the inhalation. And so our inhalation, if you have obstructive lung disease, is much more prolonged. So if you look at the normal blue curve, if you remember before I said after 1 second, we normally have at least 75% of the air, and then by 3 seconds, we're usually close to 90%. But the red curve is obstructive lung disease. And what you can see is there is a real blockage of air leaving. Those airways are collapsing down on them. However, without the force over time, those airways will relax slightly so you can get more and more air out. And so at the 5 second mark, the FVC will be almost normal for that size individual, but the FEV1 will be markedly reduced. And so this is a classic finding found in untreated asthma, as well as that chronic obstructive pulmonary disease, COPD. Now, in restrictive lung disease, as opposed to obstructive, we have decrease in lung volume because we have problems taking air inside the lung. And this is usually due to a neuromuscular problem. We have stiffness in the chest wall, or we have an abnormal chest wall, such as seen in scoliosis or in marked obesity, where everything is pushing the diaphragm up so the chest cavity is smaller, or in lung diseases which give fibrosis to the lung tissue, such as seen with COVID-19. So in this diagram, the green is the normal. Blue at this point, you should recognize being that obstructive lung disease we saw before. And now this orange one is the restrictive lung disease. What you can notice is there is a marked reduction in FVC. And the FEV1, if you look compared to normal, is reduced. However, the ratio between FEV1 and FVC is either going to be normal, or actually oftentimes it's quite high, like in the 90%. So that's obstructive and restrictive lung diseases, and testing that can be done with a spirometer. But there is another machine, very inexpensive and handheld, that can be done in your house all the time, and that's a peak flow meter. So this is one type where when you take the cover off, you fold it behind and it gives you a handle. And then there's another one like this, and then there's also tubular ones, which I forgot to bring to show you. What they all have in common is they have an area that is measuring airflow. And in the middle, there is this marker, which as you exhale will raise. On this side, there's usually things that you can move to set, like here is my peak 100% and here is my danger zone. But for us, we can just ignore those side things. We're only going to be interested in where this center one moves. And this is what is used most commonly to determine, like, are you having an asthma attack? Is your asthma getting worse? Is it getting better? Is your pneumonia getting worse? Is it getting better? Because we can actually look at how much you're able to exhale. And so take a moment, stop and read these directions and how to do it properly. And realize that you can't just do one testing. We usually do 3, and then we take an average of the 3. And yes, it is not uncommon if after doing it, it does make you cough a little bit because your lungs are not used to having that forceful exhalation. So when we look at the values that we are obtaining are called your peak expiratory flow, PEF. Sometimes it's called the peak flow rate, PFR, or peak expiratory flow rate, PEFR. And what this does, it gives us the maximum speed of exhalation, how fast you're able to exhale, measuring the airflow through your bronchi, thereby letting us know are the bronchi collapsing on themselves. And as you would expect, normal values depend on your sex as well as your height. So this table has 4 different heights for men up there. And as you can see, all the men have greater values than the women just because their chest cavity is larger and the effects of testosterone on their muscles. And when you look at the graph, what you notice is as you were a child and you're increasing in size, these numbers increase. But after your 20s, as you age, these numbers are decreasing due to a decrease in the strength of your respiratory muscles. And this helps explain why the elderly are much more prone to have respiratory problems with any type of lung disease, because they're not able to forcefully exhale gunk that is collecting in their airways. The other very interesting thing about peak expiratory flow is that there is a marked diurnal variation with significantly lower values found in the morning that are found in the evening. So if you're using this to monitor yourself, you either need to only do your values in the morning or do your values in the evening, or even better, write both evening and morning values over time. This one, you can see that over time, there was a slight upward increase in function, showing whatever that treatment this person was actually having a positive effect. So this is the chart for normal for you to use to decide, are your values normal or not, okay? And so basically, you're gonna look at the 20-year-old line, and over here is your height in centimeters, whereas over here is your height in inches. So 60 inches, the bottom curve is if you're 5 feet. The top curve for ladies is if you're 5'9". For men, the bottom curve is 5'3", and the top curve is 6'3". So kind of take your height and look to see what the predicted is for your height. And so I want to talk about asthma just for a second, because we said this is the biggest place where this is used. And with asthmatics, their airways are narrow due to 2 causes. Number one, they have the swelling of an inflammatory reaction going on in their lungs. But the second thing they have is bronchospasm. And so they have a reduced airflow when they exhale, especially when they're forcefully trying to exhale. In fact, they can increase the amount of air they exhale by pursing their lips and only having small amounts exit at a time. And so when they are doing these testing, there's a decrease in their peak expiratory flow. And so they can look at these numbers to decide, yes, it's down, but you know what? I can just call my doctor and I'll just have some meds added. Or if it's super severe, I know I need to get to the emergency room. And if it's even worse, it's like, I need to not drive myself to the emergency room to have an ambulance come give me some medications because I could die on the way to the emergency room. And so asthmatics, when they are fragile, know these numbers and have rescue inhalers, which can get rid of the bronchospasm and move them from one category to a better category until they can get treatment to treat their acute asthma attack. And with that, I am done with this section, and I will see you again shortly. And I hope you all have a great day. Thank you.